今日咧多謝蕭醫生咧又再上嚟幫我哋講一個叫 surgical airway。其實呢一個talk 咧係part of 我哋一個叫 paint course。咁我哋由2019年開始搞，而家搞2個 class 啦。咁咧就當中咧我哋有一啲dietetic 嘅 lectures 嘅。咁我哋就發覺我哋不如將嗰啲 lectures 咧就錄影咗，咁啲 learners 咧就可以用佢嘅自己時間去睇，咁跟住咧嚟到我哋 centre 咧就專係做 simulation 咁樣樣。好，咁就請阿蕭醫生講呢個 surgical airway。
I have to deliver this lectures in English as this lecture is meant for a wider audience. So I probably speak about this topic for about 25 times to a range of different specialties. And if this lectures you find too easy or difficult, please let me know, and I will make adjustment and answer your questions if we ever meet again. This is a talk mainly on surgical airway for children, and for children I meant those younger ones, which is not mainly adults. They have a specific anatomy and physiology that we have to address, so we can make management accordingly, and I'll tell you why I did that. And no disclosure, many no copyright materials from the journal articles and from internet and some from product catalogs, and please do not distribute this. And this is meant for internal use and educational only. And the thing we dread is about CICV, cannot intubate, cannot ventilate situation. So how often is that? Strangely, we do not have a prevalence in pediatrics. We only estimated this for adults who go for any surgery. If it happens for the surgery of the head, the prevalence is about 4 to 5% in adult. So those people who ever have surgery in the head is probably maxfax or ENT surgery. So if they have obesity for some sort of morbidity or morbid obesity operation or gastric operation, the prevalence is about 25%. So we are seeing a wide range of prevalence in adults, and we do not actually know how often is that in children. And we do have some agreements. So we have the Difficult Airway Society, and they particularly have this CICV in their mind and made a flow chart for this. But the curious thing about this is DAS, but it is published by the American Pediatric Anesthesiology Society. So actually, it is meant for anesthesiologists. So what about the clinicians working in the ward? What about the clinicians working in A&E? How are we going to paralyze, anesthetize the child if we are seeing an airway obstruction? And even so, they meant for 1 to 8 years old. They dare not publish a guideline for those 0 to 1 year. And even within this guideline, they say if you cannot intubate, cannot ventilate the patient, you call for specialist help. And if ENT available, you can do some tracheostomy, you can do rigid bronchoscopy. If not successful, you can try cannulate with cricothyroidotomy, or you can use a jet ventilation. So you can find how to do exactly these two things through these two YouTube links. They publish it, and it's free for everyone to use and see. So again, they don't have agree on one particular thing. Even the DAS or the ATL, the Advanced Life Support, do not agree on when is a suitable time for needle cricothyroidotomy. A DAS say maybe you can do it by 8, and maybe you can do a scalpel cricothyroidotomy by 8. If smaller than 8, you can try a needle one. But ATLS is more safe. They say that if you are 12 or older, you can try a needle, but a smaller one, you can try scalpel. So you can see they are contradicting each other, and no one mentioned what to do if the patient is an infant. So I'll tell you what I suggest, what I think may be the right thing to do by the end of this talk to understand why a pediatric airway is so different from the adults and why the management is so difficult, and if you happens to call us and if a ENT arrives or you have a surgeon that is trained with TB or tracheostomy, what do you expect they will do with the baby in your hand? So this is why the pediatric larynx is so different. There are like a dozen of points we often ask in our fellow examinations on what is the difference of a pediatric and an adult larynx. The first thing is that a pediatric larynx is very soft. The cartilage is probably not palpable, and you can see the higher bone, the thyroid lamina, the cricoid, they are all redox into one another. And so that's why the cricothyroid membrane is very often not palpable or even non-existent in very young children. A lot of people ask, when will this descent happen? When will the cricothyroid membrane happen? I do not have an answer. Even I search many books and literature and talk to many writers. And one thing is that it actually is very dependent on the growth of the child, particularly the height of the child. And another thing is whether the patient use the larynx, whether they use it to vocalize, that encourage the development. Very often we see a child 3 to 4 years old, but with severe cerebral palsy, they have what we call a very infantile larynx. The larynx didn't develop much at all. So actually this development is very dependent. And by it, other than the redox of the thyroid and the cricoid cartilage, the arytenoid is very soft and comparatively very big, and the vocal length of a baby is very small. By newborn, it's about 1.5 to 1, meaning the 1.5 is the vocal length and 1 is the cricoid lamina. It's a arytenoid length. So it's actually like 1 to 1.5. And while in a mature larynx, in a man, it's approximately 5 to 5.5 to 1, and in a woman, it's 4.5 to 1. So actually, the vocal cord length dictates your glottis length, which is a lot of increments when the patient mature. So a lot happens when a baby develops from an infant to a teenager. The larynx actually descend, and a lot of coordination go on. They learn from doing suckling movements, suckling, breathing coordinations to vocalization. And actually, vocalization is not just making noise. They make a lot of very delicate movement to enable the range of languages that we see in the world. And a lot of maturation goes on regarding the use of the muscles and also the caliber of the airway. So the larynx is not one organ, it's an ever-changing organ. And by this is a lot of the physiology, is particularly in the development of our speech, is not very well known as well. So can we do a cricothyroidotomy in a baby? Probably very difficult. Even you can palpate the cricoid, palpate the thyroid, the cricothyroid membrane is probably very, very narrow. Even you can put in a needle, it's just for a gush of air. And you can probably, very difficult to insert a tube with a reasonable size to ventilate the baby, especially if you have a very high carbon dioxide level. So if you can ambulate a baby, some oxygen can already go in. Probably a cricothyroidotomy cannot help you much at all. But if it's a complete non-baggable situation, yes, you can do a cricothyroidotomy. So most of the time, if you ever call us, we will try to establish the airway by using a rigid bronchoscopy. By that, we insert a metal tube, hopefully squeeze away the soft tissue that is blocking the way, and if possible, take it away, obtain some histology or biopsy to confirm the diagnosis, relieve the obstruction, and then allow time for intubation or even a tracheostomy. So a lot of people are very trained with flexible endoscope, respirologists and physiologists. I have to stress that flexible endoscopy is a beautiful technique. You can see the nose, you can appreciate the movement of the larynx, particularly the vocal cord, and if you're trained enough, it's probably very easy to intubate the child as well. But the downside of a flexible scope is you do not ventilate much of the child because the scope itself takes up most of the lumen of the larynx when you try to insert the tube. You can use some nasal or oral pharyngeal oxygens to help you with prolong the time for you to do a flexible laryngoscope. But the fact is that the tube itself and the scope itself is taking up many caliber inside the airway, so probably you lost most of your ambulatory ventilation airway when you do a flexible scope, and you lost the tactile sensation because it's a rather 2D sensation, which compared to, of course, rigid bronchoscope. And you lost, a lot of people try instrumentation, they try balloon, they try laser with the flexible bronchoscope as if they're in adult. But again, this is very difficult in babies because of the caliber. So if you insert a scope with a working channel and with a suction, the scope is probably too large, and the baby would not have that long of time for you to instrument the baby. So I like to play this video very much. Here. This is the real life, what I see when I use a flexible endoscope before the rigid bronchoscopes to assess the airway. So you can see, this is a typical laryngomalacia baby. Well, otherwise the baby is quite healthy. They only have a bit of noisy breathing. But in a baby, it's like fast forward. This is not a fast motion movie. So actually when you see a baby, the younger the child, the faster the breathing, and how good you are to intubate that hole is a very questionable thing. So I have to say many people are very good. They can still intubate the baby this way. But you have to bear in mind this is a very difficult and very rare situation that you can perform this and practice this in a real life baby. So very often an intubation is difficult just because they are small and they breathe very fast. So this is how we do it if we just do diagnostic bronchoscopy or diagnostic laryngotracheoscope in a clinic. We face the patients and with the monitor at the back of us to see particularly the nasopharynx, the oropharynx, hypopharynx, and the vocal cord situations, and sometimes we get a peep of the upper ear trachea as well. But if you are to intubate a baby, I strongly advise you to take the right-hand side position. You will stand at the head of the table and try to intubate the patient that way. But in that one is anesthetized child. So you can see if you do a diagnostic or intubation fibroscope, the position is very different already, a seated versus a sleeped patient. And bear in mind, your left right will be changed. So either way, you have to get trained to do it precisely, I'll say, when you face the patient. So we go ahead to rigid bronchoscope. This is, I get it from a university, wrong spelling, of Iowa. They have a large set of photos and how to do in their Iowa protocol. And it is free for everyone to use and read. So this is how they do it, and actually how we do it as well, is that we are seated at the back of the table. We position the child with the leg extended, and we put in a rigid bronchoscope with the airway, with the ventilation part, and the anesthetist is to the right side of our table, and we put the television at the back of our tables and to visualize the airway. So this is the usual setup for rigid bronchoscope. We have a laryngoscope, which is attached with usually mouth ET tube pieces to provide supraglottic oxygen or some jet ventilation, and then the rigid bronchoscope inserted through a rigid laryngoscope. So we can use a Macintosh if that is an ordinary case, or a video laryngoscope to help with insertion of the rigid bronchoscope, or the rigid bronchoscope set sometimes come with breathing portals, what we call a slaughter blade laryngoscope set. So a lot of gadgets as well for visualization, suction, forceps for foreign body removal or biopsy, and sometimes lasers as well. So these are the laryngoscope, and you can see that we can attach the breathing with oxygen or jet through the slaughter blade laryngoscope. So this is the set of rigid bronchoscope, and usually comes with a very long lens, but we can also peep through the hole. And the bronchoscope itself has a lot of portals, and what we call the upper portals and down portals. The upper portals, it can come with the vision side, and D is the ventilation side, the C is the working channel, and if we have to peep through it, we can insert light sources through the B portals. And it is the upper part, and the down part is, there are two things about it. First is a bladed, it's a sideways bladed, and another thing is that not only the end hole can pass through things, the side hole also slits. So if some telescope or the lens pass through the end hole, the side hole can still ventilate the baby. Or if we are looking into one of the main bronchus, we hope that contralateral bronchus can also be ventilated through the side holes. So very technical on this one. So when we actually do the bronchoscope, we attach it this way, attach the anesthesiology or airway circuit, and insert the telescope and the working channel. And if we have to remove a foreign body, this set also comes with something called optical forceps, that we use a long piece of lens through a forceps to grab something. And this can be inserted through the lens portals of the bronchoscopes to remove foreign body if we have to do that. So bronchoscope size can be matched with the patient's airway size. And of course, matches with tracheal tube sizes, but these are very technical things. So findings, what do we see or what do we expect when we do a bronchoscope? Very often we missed, but we nowadays insist patients should do a bronchoscope and a laryngoscope together. We see cleft, submucous or wide open cleft. Big tonsils are sometimes the reason for difficult intubations. And this is glossotosis. This is one of our very important things to check out, is that some patients, they may have a tongue tie, or they have a retronavial or micronavial, or they have a stiff jaw, that the tongue is not moving very well, and by that they compress onto their own airway. It can be graded, depends on whether we see the groove between the tongue and the epiglottis. If we see it, it's quite normal, it's grade 0. If we see the groove, but the epiglottis is already touching the posterior pharyngeal wall, is grade 1. And if the groove is not completely seen, the epiglottis compressing onto the posterior pharyngeal wall, is grade 2. And the last one is the tongue pushing on the posterior pharyngeal wall. You have no view of the epiglottis, that's grade 3. Usually these happens in Pierre-Robin babies, micronavial babies, usually syndromal, but sometimes we see it in children with severe obstructive sleep apneas as well. Some people suggest this may be a combination of anatomical causes and muscle hypotonicity. That is maybe nowadays the cause for OSAS in adults and children actually. And many people have good progress or good response with something called physiotherapy of the tongue, what we call myotherapy, because they treat particularly this condition. They make the tongue has a more tone and move more forward, especially when the patient is partially sedated or sleeping. So glossotosis. And Laryngomalacia, particularly in younger children. Victor, my boss, my teacher, used a Hollinger classification, which classified this laryngomalacia into 5 types, which is a morphological typing. Type 1 does not mean that it is more severe or less severe compared to type 5. So nowadays, many people still use Hollinger because he described it. But many people change to this Iowa classification, which classify the anatomy into type 1, 2, and 3. Type 1 is the original moving forward. Type 2 is the AEFO moving inwards, laterally moving in, posterior moving in, or the third type, the epiglottic flop to the posterior. So this type, I always said, it predicts how are you going to treat it. So whether you trim the lateral, or you trim the posterior, or you fix the epiglottis in the front. So many neurosurgeons change to this type. We use it interchangeably because actually it's very similar to Hollinger's, but just Hollinger is more morphological at describing. So we use it interchangeably. But type 1 does not mean that it's more severe than type 3. So it's another misnomer commonly exists. There is no such thing as the severity grading of the laryngomalacia. We just see the patient clinically. Are they making noise? Are they making a very loud noise that worries the mother, sometimes with apnea attack? Or third, are they impaired? Whether they have impaired breathing, such as in the case of obstructive sleep apnea, or they use assistance in the daytime, or worse, are they impaired with the growth? So actually we see the clinical to determine the severity, but not the morphology to determine the severity. And other things such as subglottic stenosis and web conditions, these are very often presented as stridor. You can see vocal cord paralysis as well. These are older children you can see. You can see the vocal cords, they are not moving symmetrically and they are wasting of the true cords. And the webs and subglottic stenosis can be congenital, or they can be a sequence of a previous procedure or intubation. Webs are usually congenitals, but can also be post-intubation or procedural. And papillomatosis, these are getting rare and rare now. Still, they happens, and usually in children from 2 to 4 years old. Depends on the how's their immunity reacting with the virus, and another thing is whether they get a more virulent serotype of the virus to determine whether they will present early or present late. Usually they present with hoarseness first if they're benign, but very occasional in an immunocompromised child with a very virulent strain. They may present as airway obstruction, but well, not in Hong Kong, maybe in some part of China and Southeast Asia. And vocal cord nodules are rare, very common, very rare in other parts of the world, but common in Hong Kong because of the way we raise our child. Sometimes they come with a sudden loss of voice because of screaming and then hemorrhage into the adventitia or the laminar propria layer of the vocal cord, and then they have scarring and nodules formations. And these patients, they rarely come with airway obstruction, but they will have sudden onset of aphonia, which worries your pediatricians a lot. Cleft is rare. And usually it happens with cardiac conditions together, but very occasionally we see isolated cleft, which is just a little bit of a widening of the interretinoid groove. But if they have the widening with aspirations, we say that they are cleft. But if they have no aspiration, we will say there's a gray zero cleft that we don't treat. And cysts can be a cyst or a post-intubation cyst, or it can be a cyst or cystosome, or sometimes it can be a hemangioma. A few traps have been laid down for us before as a bluish cyst in the subglottis. And tracheoesophageal fistula, a repaired one or a persistent one or a missed one, because some of them, they have double holes, upper and lower holes, that the pediatric surgeon, when they do the TEF surgery, the baby is really very small. So very on very rare occasions, there may be a tiny hose that is left in the distal airway, but this is rare. Most of the time, we see the inverted 品字形 sign that we have the two main bronchus and the stump. The stump, they have repaired it and clipped it already on the esophagus side, but occasionally they have a blunt opening at the carinas. Or they can have a dimple at the carina, as in the lower picture. These patients, they do not have airway obstruction, but sometimes they have infectious episodes, and usually they are older children. They come with episodes of recurrent pneumonia or sometimes chronic lung diseases. And the last, we have tracheitis. You can see very bad tracheitis, bacterial tracheitis, or sometimes what we call pseudomembranous tracheitis can be a sequelae of viral infections and superimposed Staph aureus or Pseudomonas infections. So these children, they just come in as a crib child, but very toxic, some like a very toxic crib. So they worry about it, and then we try to intubate these children, and then we find all these discharge and bleeding mucosas in the airway that require repeated toileting, moisturization, but all of them, they get better, I have to say that. And tracheomalacia, very often we have difficulties in making this diagnosis. Again, this is a clinical severity gradings. If we see, really featureless trachea, we don't see the normal arch and arching mucosa and the posterior wall, really featureless like a muscular tube. But the baby is not making any problems. They do not have a breathing problem, they do not make noise, they do not have problems with eating or breathing, then we sign off as a mild one. Not depending on the morphology. But if you look for it, it can be featureless, or it can be what we call ballooning of the intercartilaginous membrane. So you can see, while a normal trachea at cough, you can still, the tachytechia is maintained, and the posterior tracheal wall will bulge in. But in the tracheomalacia one, they have problems. Even when they have inspiration, they will have inward collapse of the posterior tracheal wall. So, and stenosis is rare, and complete rings occasionally happens, and many of the time they are not complete rings. Sometimes they are a sign of vascular malformations, and they may have a long segment of a complete ring, but depends. We have to palpate the posterior tracheal wall to be sure. And innominate artery compression is can be seen quite often, and most of the time it does not cause much problems to the child. It just see a left-sided mainly compression that is slighter on the right side. And double arch aorta, this is Victor's collection. You can see the very atypical shape of the trachea. And this is one of our case with pulmonary artery sling. You can see the sling is actually wrapped around the lower trachea and form a very critical stenosis. Luckily, the child has a Pig's bronchus that opens to the right upper lung that she can survive till 3-4 years old, that she can manage to be repaired. So foreign bodies, they can be very distressed, usually in previously healthy children. So these are the children that the emotional reaction of the parents are most severe, so we have to get it out. And this one is sweet corn, and that one is the flap of tissue paper. These are the things that we must get out to avoid the patients into distress. And the very sad cases of grapes and blueberries and beef balls, and sometimes they do not make it to the accident in emergency. But if they do, we are obliged to take this out very quickly and effectively. And soft ones like sweet corn are the most difficult one to take out. And sometimes like battery or beets or beans, they are easiest comparatively.